Welcome to Wu Yu Laser Therapy for the Open Angle Glaucomas, ALT and SLT with Dr. Nathan Lighthizer. Thank you so much for being with us tonight. We're super excited to learn from you. Next slide. I'm your host, Dr. Elise Kramer, and thank you to everyone for joining us tonight. Next slide. I will introduce our amazing speaker, born and raised in Bismarck, North Dakota. Dr. Nate Lighthizer, OD, FAAO, is a graduate of Pacific University College of Optometry. Upon graduation, he completed a residency in family practice optometry with an emphasis in ocular disease through Northeastern State University, Oklahoma College of Optometry, NSU OCO. Dr. Lighthizer has joined the faculty of Oklahoma College of Optometry and serves as the Chief of Specialty Care Clinics and the Chief of Electrodiagnostics Clinic. In 2014, he founded and now heads a dry eye clinic at the College of Optometry. Also in 2014, he was named the Director of Continuing Education as well as the Assistant Dean for Clinical Care Services at the Oklahoma College of Optometry. Starting in 2020, he has named the Associate Dean of the NSU Oklahoma College of Optometry. He is a founding member and currently serves as president of the Intrepid Eye Society, which is a group of emerging thought leaders in optometry. He was named a member of PCON 250, a list of top 250 optometrists in the country who practice progressively, provide innovative patient care, conduct optometric research, or excel in academia, and share what they have learned with other optometrists to advance the profession. Dr. Lighthizer lectures nationally and internationally on numerous topics, most notably advanced ophthalmic procedures, electrodiagnostics, and ocular disease. Thank you so much again for joining us tonight. We're super, super excited to have you.
Thank you, Dr. Kramer. Appreciate it. Good evening, everybody. I hope you all are doing well. My name is Dr. Nate Lighthizer. I'm a faculty member at the Oklahoma College of Optometry, as Dr. Kramer said. Looking forward to being with you for the next 45 to 50 minutes, about until, I guess, 7:30 Mountain Time, 8:30 Central, 9:30 Eastern. So this is laser therapy for the open angle glaucomas, mainly talking on SLT. This is usually, I could give this lecture in 2 or 3 hours. I could maybe even stretch it to 4 hours. Obviously, we only have 50 minutes tonight. So I'm going to go through this very quickly. I'm going to hit the high points, the key points. Again, as Dr. Kramer said, if you have any questions at all as we go through, put them in the Q&A box. Put them in the Q&A box, and I will monitor as I'm going throughout this lecture. I like to answer questions kind of in real time, not waiting 30 minutes from now, 40 minutes from now when we moved on to other things with SLT. So if you have any questions as we go through this, please ask them in the Q&A, and I will try to address them in real time as we go forward. So you saw my disclosures. All disclosures have been mitigated here. We're going to keep this within the guidelines of a COPE-approved lecture. If you've been to my lectures before, both in person or webinars, you know I like to poll the audience. I'm going to ask you guys some questions. This is not required. I say again, this is not required, but grab your phone and scan that QR code. Again, this is just grab that phone and scan the QR code, and that will open up my poll everywhere page. I say again, this is not required. You don't have to do it. It's just a fun thing to do. Let's poll the audience and see what percent think A versus B versus C versus D. It's completely anonymous. Nobody will know what you put. I won't even know what you put. And once again, it's not required for the CE, so you don't have to do this. Again, just a kind of a fun thing to do if you like. I'm going to ask you a question right at the beginning as we go forward here. Discuss the new non-contact SLT laser that doesn't require gonio. We will get there. Yes, we will hit that. That'll be the last thing that we discuss in this webinar. Is we will get to direct transscleral SLT. So we will get there as we go forward here. So here's my first question to you. Again, we scan in the QR code. When you go to your primary care physician, which of the following would you rather happen? Kind of a simple, silly question here. When you go to your PCP, would you rather that they prescribe you meds or more meds, or they try to keep you off of meds? Which one would you prefer when you go to your primary care physician? Again, simple, kind of silly question, but I think it applies to us to a certain degree. And I think the vast majority, 93% of you, would prefer that. I'd rather not take meds on a day in and day out, week in and week out basis. It is burdensome to have to remember that every single day. And I want you to remember that when it comes to our glaucoma treatment armamentarium. When your patients come to you, what are you recommending? Well, let's ask that question. What percent of your glaucoma patients do you offer SLT as a first-line treatment option? And I've given you, 5 or 6 answers here. Just pick the closest percentage. There is no right answer and there is no wrong answer for this. So I'm just asking, your patients that come in, your glaucoma patients, you pull the trigger on treatment, what percent of your glaucoma patients do you offer SLT as a first-line treatment option? Once again, this is not required. I want to emphasize that so everybody hears that. You are still going to get your CE credit, even if you don't answer them. A couple of people are answering in the chat box or the Q&A. That is fine as well. And when I ask this question, the number one answer is usually 0%, but there's more and more percentages getting to 20, 40, 7, 8, 9 years ago. This answer was like 90% of people putting 0%. 90% of people were putting 0%. And now, look at that. Now the number one answer in this webinar, 150 of you answered, about 36% of you are putting 20%. So you can see the percentages shifting because of the Light study, the Light trial, the SLT med study, among others as well. This is slowly shifting. Again, the answer used to be 80 to 90% A. It used to be 80 to 90% A, and very few people put the rest of the answers, and it's just swinging and swinging. We'll talk of the reasons for that in just a second. So why do we use lasers? We use a lot of lasers. The number one laser that we use as optometrists. Oh, by the way, via the chat box or the Q&A, because I know we don't have dialogue back and forth, anybody want to venture a guess? How many current states allow optometrists to do laser procedures? How many current states allow optometrists to do laser procedures? I'm going to come back to that in just a second. Does insurance? Yep, I'm looking at these questions. We will get. Does insurance have pushback against SLT first line without failing drops first? And the answer is no. Insurance has seen the writing on the wall that it is more cost effective for SLT first line than it is for drops. So you will get zero pushback. You will get zero pushback from insurance on SLT as first line because it is a first line option and has been shown to be more cost effective than others. All right. Congratulations, Patty. Got the answer correct. It is currently 12 states that allow optometrists to do laser procedures. 12 states. That number used to be 1 with Oklahoma in the 2000s, 2005, 2010, and in the last 10 to 12 years. There are now 12 states that have joined that list. So keep pushing. You may not be able to do this first line just today, but South Dakota just became state number 12 a couple of months ago. So not all lasers are clear cut. What do I mean by that? YAG capsulotomy is pretty clear cut. If somebody has a cloudy capsule following cataract surgery that's affecting their activities of daily living, what do they need? They need a YAG capsulotomy. There's really no ifs, ands, buts about it. When somebody has glaucoma, and we just pulled the trigger on glaucoma treatment, now we have options. Is it drops? Is it cataract surgery with MIGS? Is it SLT? What are the different options that we have? So we've got a lot of options. I'm guessing everybody on this call, all 1,400 of you agree that traditionally speaking, this has been our treatment paradigm. Would you guys agree with this? Drops are first. We exhausted the drops. Maybe it was 1 drop, maybe it was 2, maybe it was 3, maybe it was, God forbid, 4 drops. So it was maximize the drops, then you go to laser, and then you went to surgery. That has been the traditional paradigm over the decades and decades and decades, is drops are first, laser is second, and surgery is third. I'm guessing most of you would agree with that. I would now argue that this is our paradigm. And we've got MIGS added in there as well. And don't let me fool you on this. 1, 2, 2, 1. You can flip SLT and meds. The bottom line is you have 2 wonderful first line options. We have wonderful drops, and we've got more and more drops than we had even 10 years ago. We've got wonderful drops, but we've also got a wonderful laser called selective laser trabeculoplasty. The literature is overwhelming at this point that SLT is a first-line option for glaucoma. We'll get into that in just a second there. So, I ask you this. What percentage of your patients are compliant with their glaucoma meds? I should ask that question as well. I've asked it before. I just don't have it in this slide deck. What percent of your glaucoma patients are compliant with their glaucoma meds? And well, I'm going to go back here. Let's have some fun here. Okay. So I'm going to change the question. Okay. I'm going to clear the responses. Let's answer this again. You guys ready? Now, don't look at the question, but the question is now, what percent of your glaucoma patients are compliant with their glaucoma medications? Go ahead and answer again. 0%, 20%, 40, 60, 80, or 100. What percent of your glaucoma patients are compliant with their glaucoma medications? There's no right answer and there's no wrong answer here. Again, I changed the question. It's not this one. What percent of your glaucoma patients are compliant with their glaucoma medications? And I have asked this question many times in a live audience, and I will tell you the number one answer has always been 60%. Let's see, I'm putting it on the line here. And there it is, 60%. So this group, the number one answer is saying that 60% of our patients are compliant with their glaucoma meds, which means 40% are not. Every single one of us knows that we battle compliance issues, cost issues, convenience issues, quality of life. It's hard to remember them every single day. And that's not even talking about how many of your glaucoma patients also have ocular surface disease, also have dry eye, and you prescribe a glaucoma medication that's lowering their pressure very, very well, but it's causing redness. It's causing ocular irritation, front of the eye issues, et cetera, et cetera. So again, that burden that patients feel, I think is very real for many patients there. So let's talk, even your best of intention patients, watch this. You say, Mrs. Jones, are you taking your glaucoma drops? Oh, yes, doctor, I am taking my glaucoma drops every night. I put them in. All right, you say you put them in. Show me how you take your drops. This one's hard to see because of the shadow. Like literally puts in like 10 drops in the eye. Too much. Here's my favorite one. Scrape the eyelid, through the eyelashes, right on the ocular surface. Even the best of intention patients may struggle with getting those eye drops in. So we know there are issues and things that we battle with glaucoma drops. So laser trabeculoplasty, they increase aqueous outflow. ALT and SLT, it increases aqueous outflow. Traditionally speaking, it's been a second-line therapy after drops. Drops are first, laser is second, surgery is third, but it is universally accepted. And it's universally accepted because the glaucoma laser trial way back in the late 80s, early 90s was the first big trial to directly compare ALT to the best topical medication at the time, which was timolol, which was beta blockers back then. And what it found is that ALT was just as good as the best topical medication at the time in terms of IOP reduction, visual field status, optic nerve status, et cetera, et cetera. So ophthalmology took that and said, we have a laser that we can do in open angle glaucoma. And here are your indications. These are your 5 big indications for glaucoma. And you will notice that all 5 of these indications have what? They all have open angles. You cannot fire laser energy into the angle in its current format. That may be changing very soon. Again, we'll finish with that with direct transscleral SLT, but you can't fire laser energy in its traditional way, ALT and SLT, into the angle unless you can see the structures, the trabecular meshwork. So all of these have open angles. I've ordered these from the strongest indication, POAG and ocular hypertension, to still indicate it at the bottom, but take it with a grain of salt. Pigment dispersion and pseudo-exfoliative glaucoma, they're still indicated, but again, there's some caveats with that. Why are POAG and ocular hypertension your strongest indications? They've looked at what are the predictive factors for success. Wouldn't it be nice if we could predict success? Meaning this, if we do SLT in your eye, it's going to work. If we do SLT in Mrs. Jones' eye, it's going to work. Mr. Jones' eye, it didn't work very well. Wouldn't it be nice if we could say it's going to work in you, it's going to work in you, it's going to work in you, it's not going to work in you, so we're not going to do it. It's not going to work in you, so we're not going to do it. It's going to work in you, it's going to work in you. Wouldn't it be nice if we could do that? They've looked at that. They said, what are the predictive factors for success? They've looked at age, cataract status, gender, amount of pigmentation in trabecular meshwork, IOP status, number of medications they're on. They've looked at all of these predictive factors for success, and they keep coming back to the main and biggest predictive factor for success is pre-laser IOP. The higher the IOP, the more bang for your buck. And that should make intuitive sense. Your eye drops lower the pressure more when the pressure is what? 28 or when the pressure is 11? On a percentage basis, it's likely going to lower their pressure more when the pressure is 28 compared to when the pressure is 11. So the biggest predictive factor for SLT success is the pre-laser IOP. The higher the IOP, the more likely you're going to get a robust pressure lowering effect, like 20%, 25%, or 30% plus pressure lowering. The second biggest predictive factor for success is the number of medications they're on. And there is some controversy to that. Many studies say it's the number of medications they're on. Others contradict that. But generally speaking, what percent IOP reduction do you expect with your first med? If you put a patient tomorrow morning on a prostaglandin first-line therapy, what do you expect for pressure lowering? And I'm guessing most of you would answer 25 to 30%, and I agree. 25 to 30% for your first drop, all right? How about your second drop? You put a patient on a prostaglandin a few years back, and now they need a second drop to control their pressure. What do you expect for a pressure lowering percentage for drop number 2? And most of you would say 10 to 20%. It was 25 to 30% for drop 1, and it's 10 to 20% for drop number 2. All right, they're on 2 drops, and you just put them on drop number 3. What do you expect for drop number 3? And most of you, and I do this live, say 0 to 10%. I asked our glaucoma specialist that question. I said, what do you expect for drop number 3 when you put them on their third drop in terms of pressure lowering? And our glaucoma specialist said 0 to 2 points. 0 to 2 points, meaning you're not going to get much. Here's my point. If you're using SLT as a third drop replacement, meaning they're on 1 drop, they're on 2 drops, you're about to add a third drop and you say, you know what, that's really burdensome for the patient. Let's go to SLT instead. So SLT is their third treatment. What should you expect in terms of pressure lowering? 0 to 2 points, meaning don't expect a whole lot. Your 2 biggest predictive factors for success are pre-laser IOP and the number of medications that they are on. When does SLT work best? Earliest in the course of therapy, earlier in the course of therapy. Those are your indications. POAG and ocular hypertension are your top 2. What laser procedure is now used for narrow angles and ocular hypertension? If your patient has very, very narrow angles, that's going to be a contraindication for an SLT in its current form, advanced POAG. Narrow angles or angle closure, you're going to be looking at a laser peripheral iridotomy unless they are ready for cataract surgery. I'm sure most of you know that the EAGLE study, among others, have shown that cataract surgery is superior to peripheral iridotomy. But if I'm answering generally, what is the laser procedure done in narrow angles and angle closure? It'd be a laser peripheral iridotomy. And once the narrow angle is well controlled with a PI or with cataract surgery, then SLT becomes indicated. So the angles are opened from the laser PI or cataract surgery. And once the angles are opened, now SLT could be indicated. So contraindications, everything else, as you see here. Again, remember your 5 main types of glaucoma. There they are. POAG, ocular hypertension, and low tension are your top 3 indications. All right, so let's talk on SLT. I'm going to skip by all of this ALT stuff, okay? ALT, there's only one reason why somebody would do an ALT in 2024 instead of an SLT. Anybody have any guesses of why would somebody do an ALT instead of an SLT in 2024? And the answer is it's because you don't have an SLT laser in your office. You've got an old green laser, an argon laser in your office, and you haven't invested in the money to buy an SLT. That is the only reason, and I'm not sure it's a good reason, to do ALT instead of SLT. All right. Okay, so we're moving on to SLT. So how does SLT work? SLT works differently than ALT. ALT is a mechanical effect. You guys have all seen the effects of an argon laser or a green laser on the retina. PRP. Anytime you've seen PRP burns, that is a retinal burn. It's killing the tissue. An ALT is a argon laser. It's a green laser, and it is photocoagulating the trabecular meshwork. It is mechanically damaging the trabecular meshwork. Can you clarify the new study regarding SLT being less efficacious post-medication versus no medication? We're going to SLT. Yep, and I'll show the contraindication slide again. SLT being less efficacious post-medication versus no medication. There's not any great data out there. Now, if they're on meds, like I said, if they're on 1 or 2 meds and an SLT is done, it is going to be less effective. The SLT is going to be less effective in terms of pressure lowering than if they were on no meds. You're going to get the greatest effect, the greatest bang for your buck when the pressure is the highest and when they're on no medications. Now, if they've been on medications and the medications are now pulled and the pressure has gone back up, I'm not aware of any great evidence. Again, there's some that say it, some that don't, that the SLT is going to work less because they were on prior meds than if they were not. Again, the evidence is mixed on that. Some say yes, some say no. I think there's more on the no side. A patient being on prior prostaglandins or prior beta blockers doesn't have a big effect on whether that SLT is going to work. If my patient took prostaglandin for 3 years, 10 years ago, I'm not aware of any great evidence that says my SLT is less likely to work 10 years later because of that prostaglandin they took. Is a history of herpes keratitis a contraindication to doing SLT? One of my patients had a really bad reactivation due to a procedure. That would be a relative contraindication, not absolute, but anytime that you are creating inflammation in the eye, which is what SLT does, you're creating a little stress inside the eye, which is what SLT does. That is a relative contraindication. Does that mean I absolutely would not do it? No, but I would educate the patient extra on that, understanding that what happened to your patient is a risk, and it's a bigger risk than somebody that's never had a reaction from herpes simplex before. So it's a relative contraindication, could be done, but I would be a little bit more cautious in that particular patient. If a patient is already on 1 drop for a while and the IOP is starting to creep up, would you add a med or consider SLT given that SLT works best first line? So again, the question on this is, all right, so the IOP is creeping up. Is the patient taking the drop? If the patient is not taking their drop, well, then that's why the pressure is creeping up. And in that case, I would stop the drop because they're not taking it, and I would do an SLT, and hopefully that will bring the pressure down. If they truly are taking, and I believe that they're taking the medication, their first drop, and yet pressure is not meeting target, absolutely I would go to an SLT. Because if 1 drop, I believe compliance really tanks when you go from the first drop to the second drop. When you add that second drop in, that's going to be more burdensome to the patient. So they're on 1 drop, they're taking it, there's no side effects, but yet pressure is higher than I'd want on target. I would have no problem adding in SLT as the second drop replacement. Understanding it's not going to work as well if it was the first drop, but I would still have no problems doing an SLT there. And absolutely, could you have the patient prophylactically treated with Valtrex, things like that? The answer is yes. I mean, if you really had to go to SLT, I would absolutely pre-treat them with Valtrex to try to prevent that from happening. It's a great point, and I have done that in a patient or two as well. Yep, so awesome question. So SLT, remember, it's biologic, it's inflammatory. This is sublethal. It's not damaging and killing the tissue, a crater like ALT. Can you see the effects of an SLT a month ago, a week ago, 6 months, a year? The answer is no. You cannot see the effects in the angle when you do gonioscopy because there is no permanent structural damage that is visible to the naked eye. What does this do? It just creates a tiny little inflammatory response. I tell patients, your own body's going to do most of the work. This very gentle laser, I'm not even gonna be able to tell any damage is done. It's very gentle, just puts a little stress on the drain. And when there's a little stress on the drain, your own body's cells will react to that. Mrs. Jones, when you're sick, what responds to that? Your immune system does, doesn't it? And when we put a little stress on your drain, your immune system is going to respond to this and starts to clean up the junk in your eye drain. If you clean up the junk in your drain in your bathroom sink, what happens? The water flows out better. And when we clean up the junk in your eye drain, the fluid in your eye will drain out better. Your eye pressures will go down. And that's how we help to control glaucomas. That's how I explain it to patients. Your own body's going to do most of the work. This laser is just going to put it in the right position, little stress. Your body's going to do most of the work. Now, the biggest downside with this laser is it may not last forever. It's not going to last forever. The effects are going to wear off with time. But here's the good news. When it wears off, we can do it again. SLT is very, very repeatable. How about using drops after first using SLT? So that's, I wish we had more time, to go over this. But that's a long-winded answer. The answer is yes, you can use any drop after an SLT, any drop after an SLT. Now, there are some that believe that SLT and prostaglandins don't pair the best because SLT is an inflammatory outflow laser and prostaglandins are an inflammatory outflow drop. If you go to your PCP tomorrow and you have high blood pressure that requires multiple medications, high blood pressure that requires multiple medications, are they going to put you on a beta blocker and a beta blocker and a beta blocker and a beta blocker? No, they're going to mix and match in different mechanisms, ACE inhibitor, beta blocker, angiotensin 2, et cetera, different mechanisms, different modalities. There is some literature out there that says, you know what pairs best with an SLT? You know what medication pairs best with an SLT? An aqueous suppressant, like a beta blocker, timolol, a CAI, a brimonidine, things like that. So that's a long-winded answer. Clinically, in the trenches, I will tell you that if they're on an SLT and it holds and it's wearing off over time, number one, I'd repeat the SLT. But if you need to add a drop to the SLT, they need 2 treatments, an SLT and drops. You can add any drop clinically to an SLT. When an SLT is done, do you still follow the patient quarterly? Yes. Nothing changes. Nothing changes, Mrs. Jones or Mrs. Jones. I'm still going to see you 2 or 3 or 4 times a year, depending on your severity of glaucoma. This is not a cure. I still need to check your pressure. We still need to do gonio, visual fields, PACs, ERGs, et cetera, et cetera. If you can't see where the treatment was done, can you retreat the same area? This is the beauty of SLT, is it is so forgiving and so flexible that it doesn't really matter. We're going to finish with direct transscleral SLT, where you're not even putting the laser burns in the angle. You're just putting them on the surface of the eye. It is so forgiving and so flexible, it doesn't really matter. If you hit this spot, and then hit this spot, and then hit this spot, and then you came back and hit that spot again, it doesn't matter. It really doesn't matter. That's the forgiveness and flexibility of SLT. Is it possible to repeat SLT more than one time? The answer is yes. We'll go get to that at the end there. The answer is there is no limit now. How long is the average SLT effectiveness? We're going to get to that right here in just a minute. How do you manage the inflammation? Any steroid needed? We'll get to that in just a minute here. When do you repeat SLT? We'll get to that in just a second. And how do you feel about beta blocker drops in those who are taking beta blocker orals for hypertension? Yeah, it's a good question. If they're on oral beta blockers, I don't have any major problems with putting them on topical beta blockers as well. I still find an effect on that. Truth be told, I don't use a lot of beta blockers topically. I do a lot of SLT. We use prostaglandins. We've got other medications as well. So I use some beta blockers, and I don't have a problem using topical beta blockers if they're on oral beta blockers. Existing evidence for efficacy of repeat SLT. We're going to get to that right now. So let's talk on the evidence here. Let's talk on the literature. When is SLT indicated? Here's your patient, 60-year-old male. Pressure is 26 in both eyes. Hasn't had an eye exam in 10 plus years. Wife drug him into the office. You can see the nerve. You can see the visual field. IOP is 26, 27, 28. Look at that superior rim thinning. Inferior nasal step. This patient has glaucoma. What would you start them on first line therapy? What's the evidence say? This is the SLT med study. This was the first big trial. It was released in the United States in 2012 out of Will's Eye. I know all of you have heard of Will's Eye. And it was the first study in the United States to directly compare prostaglandins to SLT first-line therapy. Prostaglandins, SLT, first-line therapy. And it compared it in terms of IOP reduction and the number of treatment steps. IOP reduction and the number of treatment steps. So what it did is, all right, I'm going to split all of you guys up. 750 of you are getting an SLT first line, and 750 of you are getting a prostaglandin first line. And we're going to check your pressure every 2 months for a year. This is a one-year study. One-year study. We're going to check your pressure every 2 months. If you don't meet target pressure, you're getting more therapy. If you were in the SLT arm, you got more SLT. If you were in the drop arm, you got more drops. That was the number of treatment steps. Here were the results. After 1 year, SLT lowered the pressure 26%. Prostaglandins lowered the pressure 28%. That did not reach statistical significance, so the results were the same. They were equal. The number of treatment steps in the SLT group, 11% of patients did not meet target pressure during the study and therefore needed more SLT. In the prostaglandin group, 27% of patients did not meet target pressure and therefore needed more drops in this one-year study. Why do you think a higher percentage of the drop arm was not meeting target pressure during the one-year study? What do you think? Compliance. Simply put, it is compliance. That also did not reach statistical significance because of the N number. That was their ultimate conclusion. IOP reduction was similar in both arms after a year of follow-up. More treatment was necessary in the med group, although that wasn't significant. These results support the option of SLT as a safe and effective initial therapy in open-angle glaucoma and ocular hypertension. Study out of Israel way back 20 years ago. SLT is effective and safe as a primary treatment for patients with ocular hypertension and open-angle glaucoma. American Academy of Ophthalmology, their preferred practice patterns. That was the statement in 2017. It can be considered. That is the statement in 2022. It can be used. Notice slightly stronger wording in 2022 compared to 2017. Here's the big one. SLT versus eye drops, the Light trial. And I'm sure every single one of you has heard of the Light study. This was released in 2019 out of the Lancet, out of the UK, the United Kingdom. And I'll go right to the conclusion. SLT not could be, should be offered as a first-line treatment for open-angle glaucoma and ocular hypertension. Wait for these words, supporting a change in clinical practice. This is some big words there. Should be offered as first-line therapy, supporting a change in clinical practice. Gone are the days of drop 1, drop 2, and then drop 3. This whole mindset of interventional glaucoma, meaning let's take some of the burden out of the patient's hands on drop 1 and drop 2 and drop 3. We've got wonderful MIGs, and we've got wonderful drug delivery, and we've got a wonderful laser now, and we have wonderful drops as well. But asking Mrs. Jones to take 3 drops throughout the day is burden, and we need to change our clinical practice. That was the Light trial. Huge study. 3-year study, multi-center, randomized trial. You can see the N numbers. Huge N numbers. 325 plus patients down each arm. 5 times less adverse events in the SLT arm versus the drop arm. And here is the money bullet right there. 75 to 80% of patients were drop-free. 75 to 80% of patients were drop-free at 3 years. That is the number that I told patients. This was released in the spring of 2019, this study. Spring of 2019. In 2019, 2020, 2021, and throughout most of 2022, that was the number that I told Mrs. Jones. When we diagnosed with glaucoma and we were discussing drops versus laser first line, pros and cons of drops versus laser, that was the number that I quoted. Is there, Mrs. Jones, if we decide to do this laser, which, oh, by the way, is what I would choose for my eyes, there's a 75 to 80% chance that we will keep you drop-free for the next 3 years. The biggest downside is this laser is not going to last forever. The good news is that we can repeat this again and again and again. 75 to 80% chance to be drop-free. Oh, by the way, how many needed surgery? Invasive tube or trab, an invasive glaucoma surgery in the first 3 years. It's a low percentage. Remember, these patients were just diagnosed with glaucoma. 11 of the 323 in the drop arm, 11 of 323 needed surgery. That represents about 2.3%. Again, small percentage. Most of your glaucoma patients don't need surgery in the first 3 years. 2.5%. Why do you think a small percentage 2.5% roughly of these glaucoma patients needed surgery in the first 3 years. Compliance. You guys know the answer. That's compliance. And when you eliminate compliance from the equation, a big fat goose egg. That was the results of the 3-year light trial in 2019. They kept going on this trial. The 6-year data, 6-year light trial. Here's the 6-year data. They have got quality of life questionnaires. They had 4 quality of life measures. 3 of the 4, there was no difference. And in 1 of the 4, SLT was a slightly better quality of life. So slight win for SLT in terms of quality of life. I didn't put it on this slide, but a big win in terms of cost comparison. SLT, there's a 97% probability that SLT is more cost effective than drops. Here's the number I tell patients now. 70% chance that you are drop free at the 6-year mark. 70% chance. That's a big deal. 70% chance if we decide to do SLT that 6 years from now, you will continue to be drop free. Now, don't let me fool you on this one. That's not all patients. I should say that's not just one SLT in all patients. So let's say there's 100 patients in a room. You did SLT first line on all of them. Of those 100 patients, how many are drop free at 6 years? And the answer is 70 of them. All right, 70%. So 70 of them are still drop free. Of the ones that are drop free, 62% of them needed 1 SLT, 32% needed 2 SLTs, and 6% needed 3 SLTs to remain drop free. So it's not 100% of patients that needed 1 SLT and it was good 6 years later. 62% needed 1 SLT, 32% needed 2 SLTs, and 6% needed 3 SLTs. That's impressive data. 70% chance we are drop free at 6 years. That is not the most important stat from this study. The next bullet is. And before I get to that, I ask you this question. What's the goal in glaucoma? What is the ultimate goal in glaucoma? To prevent progression, to prevent vision loss. More eyes in the drop arm exhibited disease progression over 6 years, 27% versus 19.5%. And that was statistically significant. You were more likely to progress if you were taking eye drops versus if you got an SLT. And again, why is that? Compliance. By the way, trabs were required in more eyes in the drop arm versus the SLT arm. Cataract surgery was required more in the drop arm compared to the SLT arm. That was statistically significant. And there was no serious laser-related adverse events. That was their ultimate conclusion. And I'm going to pause here and check the Q&A box again. Can SLT change eye color? I have never heard that, never read that before. I suppose there would be the incredibly rare inflammatory response where they developed a massive inflammation, massive uveitis, which has the potential, but I've never read it, never heard about it, anything in regards to changing eye color. So I've never read a case report on it. So it'd be incredibly, incredibly unlikely. If a patient does not respond to prostaglandin analog, would SLT or ALT still be effective? That depends on who you talk to and who you listen to, which study. There are some that believe that prostaglandin success predicts SLT success and prostaglandin failure predicts SLT failure because they work very similar. Inflammatory outflow. So if the inflammatory outflow drop fails, the inflammatory laser, some would believe, is more likely to fail as well. Or if it succeeds, the SLT is more likely to succeed. So depends on who you're talking about. Clinically speaking, if a prostaglandin fails, I am still willing to give SLT a shot. I may lower my expectations just a little bit. I may kind of temper my expectations a bit, but I'm still willing to give it a shot. How does SLT compare to drops for low tension glaucoma? We will get to that in just a second. First time SLT, would you do 180 or 360? That depends on how much pigment they have in the angle. For a standard POAG, ocular hypertension or low tension, our standard protocol now is 360 in one eye and then 360 in the other eye 6 to 8 weeks later. Remember, it takes 6 to 8 weeks to see the full effect of SLT. 6 to 8 weeks to see the full effect of SLT. So most people in the private world will do this eye, 360 degrees. Most studies now indicate 360 is better than 180. There is some contradiction to that in some studies, but the vast majority, standard of care now is largely 360 degrees. unless they have pigmentary glaucoma or pseudoexfoliative glaucoma. So first-time SLT and POAG, ocular hypertension and low tension, I would do 360 degrees. Why does SLT or ALT not work in 25% of patients? Yeah, it's a good question of, why does this not work in everybody? Not every treatment works in everybody. Is there something in the angle that we can't see? Is it tied to episcleral venous pressure? Things like that. It's hard to say, but I tell patients there's an 80 to 90% chance that this will work for you. Not everything works for everybody, and I don't know that we really know why it doesn't work in everybody. So great question here. I was waiting for this. How do you feel about losing patients to MDs in those states that ODs cannot perform the laser? You are so spot on in that. I've had this question before, and I agree with this question. It's pretty easy for you, Nate, to recommend SLT when you can walk across the hall and do it yourself. I completely understand, and I completely agree. And I feel for you. Every single one of you should be able to do SLT if you so desire. Because who treats glaucoma first line? I say that again. Who treats glaucoma first line? You guys do. And we have two great first line options, drops or laser, and you should be able to do both. Yeah. If you practice in New Jersey or North Dakota or California or wherever that does not have it, yeah, you're much more likely to put them on drops. I think that's one of the biggest reasons why SLT is lagged behind, because who wants to send a patient out and the patient never comes back? They were stolen by the MD. Or how many of you guys have experienced this? Anybody of you ever sent a patient for a procedure and they didn't get the procedure you asked for? So there are certainly issues that you have to deal with. Absolutely, I 100% agree with that. What would be the second line treatment if SLT fails to meet the pressure? Repeat SLT or drops? How long has the SLT been holding for? If the SLT was holding for, let's say, a year, and the patient didn't want to go on drops, I would have no problem repeating the SLT to see if we can get a few more points down 1 year later. If it's 4 months later and we got a 25% drop, but I wanted a few more points based on the severity of disease, the age of the patient, whatever it is, then in theory, I would add an aqueous suppressant to it. In practicality, you're going to add whatever works best for the insurance, and SLT will pair with any drop very, very nicely. How soon after SLT will you change an IOP? 6 to 8 weeks. 6 to 8 weeks to see the full effect of the laser. You can start seeing the effect in 1 to 4 weeks, but 6 to 8 weeks to see the full effect of the laser. What does the SLT laser cost? Combination YAG SLTs, since most lasers now are combination YAG SLTs. There's a few standalone SLTs that are 30 to 35 grand. If I was buying a laser in one of those 12 states, I would buy a combination YAG SLT. And those are going to run you somewhere between about $45,000 and $60,000. $45,000 to $60,000 for a YAG SLT, combo YAG SLT. What percent of patients choose laser versus drops? Boy, you guys are great questions. Currently, we're about 50-50. We're about 50-50, and that's going more towards laser now. It used to be like 20-80, but it's now about 50-50. How do you ensure these patients don't think they're cured? They don't need meds or laser. That's patient education. Just talking with them, going, I still need to follow you, check your pressure. This is not a cure. This is helping to ease your burden so you don't have to be on drops. It's education. Schedule them back in 4 months. We still need to follow this. This is an incurable disease. We're going to manage your glaucoma, laser, drops. It may be a combination as we go through. We may be on laser for a while. We may repeat the laser. It may wear off and we repeat it again. We may have to mix in some drops. When you have cataract surgery, we may mix in a procedure to go along with cataract surgery. We're going to kind of mix and match to what is best for you, Mrs. Jones, based on what you're telling me and what I'm seeing with your glaucoma as well. So, all right, I'm going to come back. Where can we find some legally related consent forms for SLT? If you email me, I'm happy to send you some consent forms with SLT. If prostaglandin fails, what's your next choice of an eye drop? If a prostaglandin fails, my next choice of an eye drop is likely going to be a beta blocker. It could be a combination agent like a Combigan or a Cosopt. Something could be, depending insurance. We have a formulary with Cherokee Nation, Rocklatan, Ropressa, something like that. So, All right. All right. I'm moving on. I'm going to get to these questions here at the end. You guys are doing great on the questions. I want to show some videos for SLT here. All right. Yep. But we talked about indications. We talked about contraindications. Pre-op. You know what the most important thing preoperatively is? Gonioscopy. If you want to be good at SLT, start doing a lot of gonioscopy. Get comfortable with that 4-mirror lens in your hand. Start doing a lot of gonio. SLT is all about gonioscopy. And guess what? You've already been trained in gonioscopy. You guys do that and started doing that second year of optometry school. You have the skills to do an SLT. It is slit lamp and it is gonioscopy. So slit lamp, how much pigment is in the meshwork and is their angle open enough? All right. What are the risks? This is the safest laser that we do. IOP spike is the main thing you're going to battle. Inflammation. That's how the laser works. It's inflammation. Very, very, very rare. Stromal haze edema, decreased endothelial cell count, reactivation of herpes simplex, peripheral anterior synechiae, angle bleeds, etc., etc. Procedure-wise, pre-op drops are brimonidine 10 minutes before, brimonidine immediately after the procedure. The only thing that we change is the energy. That's the only laser setting that you can adjust on an SLT. One laser setting. It is the energy. Typical starting energy for an SLT is 0.8 millijoules. And patient's comfortable. You're comfortable. You put the laser lens on the eye. This is our rapid SLT 4-mirror SLT lens. Has special coatings on it. You cannot use a regular gonio lens for SLT. You will destroy your regular gonio lens for SLT. So can you use it? Yeah, for once or twice until you destroy the lens. You can use a laser lens for gonio. You can't use a gonio lens for SLT. All right, let's watch some videos. All right, let's watch some videos here. Got about 10 minutes left. I'm watching the time. Great questions, great dialogue. Again, I wish I had another hour on this, another hour and a half on this. We'll try to get to as many questions as we can. So this is not an overly exciting procedure to watch. It is gonioscopy. It truly is gonioscopy. And you're seeing one big aiming beam. One big aiming beam. That's a 400 micron aiming beam. You cover the trabecular meshwork. And as you watch this, I always pause it. A few shots into this angle. Okay. Can you see any difference between where we're about to treat and where we've already treated? And the answer is no. Other than these little champagne bubbles, cavitation bubbles, there's no photocoagulation. There's no blanching of pigment. You put this one beam and just cover the trabecular meshwork and you move right through the angle. Average number of shots for a 360-degree SLT is about 100 shots, give or take 10 either way. So 90 to 110 shots. Obviously, you're not firing right now. We're just rotating the mirror, getting lined up, ready to do this mirror. This was back in the days of when we only had the 1-mirror Latina lens. Now we have the 4-mirror lens, which makes it a lot easier. Again, this is gonioscopy. And the precise energy setting is likely not critical. That's what ophthalmology studies indicate. The precise focus is likely not critical. I truly mean this, and I say this semi-joking and semi-not. Just put some energy somewhere around the angle. Just put some energy somewhere around the angle. Again, we'll get to direct transscleral SLT here in just a few minutes. You are watching gonioscopy. Cover the trabecular meshwork. Make sure you have the right amount of energy. Again, 0.8 millijoules to 1 millijoule. But again, that's probably not critical, is what a lot of studies indicate. And we're doing gonioscopy. Rotate, 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 rotate. When you're using a 1-mirror lens, which is what we used, rotate, 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 rotate. Now we have a 4-mirror lens. And the 4-mirror lens makes it really easy because you got 4 mirrors there. And we do about 12 shots in each mirror. We do the top mirror, the right mirror, the bottom mirror, the left mirror, and then you rotate to the top left, the top right, the bottom left. Only one rotation is required. We are in mirror number 2 right now. Again, we started in the top mirror. Why did we start in the top mirror? Because that's the inferior angle. Promise you, the inferior angle is the most open. It's the easiest to do. So we're in mirror number 2. We started in the top mirror, then we went to the right mirror. Here's the bottom mirror. Bottom mirror, which is the superior angle. Not seeing as many bubbles on this one. That's okay. My goal is to have the lowest energy that produces bubbles about half the time. That's your tissue endpoint. The lowest energy that produces bubbles about half the time. So that was mirror number 3. Here we go. Mirror number 4. Let's see little bubbles there. And we should be at about 45 shots, 46 shots, 47 shots, 48. Because again, we're going to do about 100 shots all the way around. We're only half done. We did the top, right, bottom, and left. Now here comes the oblique mirrors. We rotated it. Now we're in the obliques to do the 4 oblique mirrors. 8 mirrors, 100 shots roughly, equates to about 12 to 13 shots per mirror. Again, it is truly gonioscopy. You want to get good at SLT, you can start it tomorrow by starting to do gonioscopy on a regular basis. A couple more videos here. Show you guys a couple quick ones. Nice view. Look at that nice oblique angle. You can clearly see the trabecular meshwork. Big beam. Just cover the TM. See, if you're seeing bubbles like that, it means you're getting tissue interaction, putting a little stress on the drain, recruiting the inflammatory cells. Easy to look at the heavily pigmented angle there. Cover the TM. SLT is dependent on pigment. It's dependent on pigment. Find the TM, cover there, and boom, you can see those bubbles. Put roughly 12 shots in each mirror. All right. So post-op, we put in brimonidine. Post-op care. Does it make sense to put them on Durezol 8 times a day? Probably not. This works via inflammation. You want some inflammatory response there. However, the SALT trial, among others, have shown that SLT post-operatively, you can use no drops post-operatively, topical NSAID post-operatively, or even a steroid, as long as it's not probably Durezol 10 times a day. But you can use a steroid in the post-operative period, 1 to 3, 1 to 4 times a day for 2 to 4 days afterwards. Even a steroid is probably not wrong as well. I don't want to kill all the inflammation. I want some inflammation there, but you don't want too much inflammation, so you could use a steroid as well. Repeat SLT. Again, I'm going to skip through all of this. We've kind of touched on this already. SLT and low tension. That's what you can expect on SLT and low tension, about 15% pressure reduction. Remember, your biggest predictive factor for success, pre-laser IOP. So the downside is in low tension, they've got low pressure. So don't expect 25 to 30%, 15%. And one of the biggest benefits of SLT is right there, the diurnal control. That has been proven again and again and again. So is SLT indicated in low tension? Yes. Just temper your expectations. It's going to give you a point or two, maybe, but it's also going to blunt the nocturnal IOP spikes there. So repeat treatments, study after study. I'm running out of time. Here's more data from the Light trial have shown SLT is repeatable. It is repeatable. And there's even data out there, and that's what I'm showing you here, that says the second SLT may benefit from the first one. You may get an additional boost on the second one, meaning more effective on the second one compared to the first one, longer survival times in terms of SLT. So maybe an equivalent, possibly longer duration than after the initial SLT alone. So repeat SLT is safe, as seen during the Light trial. So there you go in terms of that. All right, diurnal control, yes. Coding and billing. There's your code for laser trabeculoplasty. That's the CMS national average. I would ask you guys this. Keep fighting for it in your state. How much do you guys get paid for writing a script for generic latanoprost? The answer is 0, nothing. That's what you get paid for doing an SLT. It's going to be a practice builder, a revenue generator on top of caring for our patients in the best way, they're less likely to progress as well. 10-day global period. Cost comparison, again, this has been overwhelmingly proven for SLT. All right, in my last 2 or 3 minutes, low energy SLT. This is where we think SLT is going. There's a study out of Italy that has been going on and releasing data for a long time. It was the reason for the COAST trial. The COAST trial is clarifying the optimal application of SLT therapy. This is what the COAST trial is doing. Instead of doing SLT full energy, 100 shots as needed down the road, meaning every 3, 4, 5, 6, 7 years, whenever they need it again, it's half the energy, half the shots every year. Half the energy, half the shots every single year. They come in for their annual visual field and their annual OCT, and they're getting their annual OCT, they're getting their annual SLT as well. When this study comes out, the COAST trial, look what they found in this Italy study. 10-year medication-free rates. Low energy SLT was by far the highest percentage, and the median time to initiating drops a lot longer. You're keeping patients off of drops longer and they're medication-free longer when you're getting a low energy, half the shots every single year. We used to say that you probably want to max on 2, 3, 4 SLTs. Now it's likely going to be annual. Again, this hasn't been released yet, but when the COAST trial, which I've been told the early results are positive, and this is released, I think it's going to change how we do SLT. Instead of full energy, half energy. Instead of 100 shots, 50 shots, and now we're doing it every single year. Lastly is automated direct SLT. I was at SECO in March of 2020, right before COVID. And there's a sub-conference of SECO called the OIS, the Ophthalmic Innovation Summit. And it's all these companies that are putting up what's latest and greatest, what's coming, what's in the pipeline. And this company called Belkin gets up there and they show a laser that looks like this. They're talking about automated direct transscleral SLT. I'm like, automated direct. Automated meaning you hit a button and it fires 100 shots on its own. Direct transscleral, no lens on the eye. It puts 100 burns right at the limbus, just like this, right at the limbus. And it takes me on average about 2 to 3 minutes to do an SLT per eye, 2 to 3 minutes. And they showed this laser being done, and they showed a video, and the treatment takes 2 seconds. 2 seconds. You line it up, you hit the button, it auto aligns and goes, boom. Treatment complete in 2 seconds. And I'll finish with, if this is going to be in somebody's office, this automated transscleral direct SLT, whose office might this need to be in? In your office.